Right. Maybe we'll get started. Some people might trickle in. Welcome to the Medical Center Hour. My name is Margaret Hayden. I'm a primary care doctor here and faculty at the Center for Health, Humanities, and Ethics. And today we're very excited to be partnering with the Health Sciences Library Historical Collections to bring you this special event. A few quick logistics, and then we'll pass it off to Dominique for the introduction and then to our lovely speaker. We're in person and on Zoom today. For those of you on Zoom, there'll be a time at the end for questions and answers. I'll monitor on the Zoom. Those of you in person, please pipe in and raise your hand. And I think the only mic in the room is right here by the podium. And so, Johanna, if you don't mind repeating any questions so that the people on Zoom can hear at that part. For those of you interested in getting continuing education credit, the slides have been circulating, and there's a stack of flyers on the table too that has info with the code that you can use for up to 7 days after the event. And if you have any questions, you can email Charlene Kaufman or ask me, and I can help facilitate that. And that's all my part. I'm now going to turn things over to Dominique Tabell, who will introduce our speaker. Thanks so much.
Thank you, Margaret. So it's with tremendous pleasure that I introduce today's speaker, Dr. Johanna Schoen. Dr. Schoen is Distinguished Professor of History at Rutgers University-New Brunswick. She's the author of 2 books, Choice and Coercion, Birth Control, Sterilization, and Abortion in Public Health and Welfare in the 20th Century, and Abortion After Roe, which won the Welch Medal of the American Association for the History of Medicine. In addition, she has edited an anthology on abortion care as moral work, ethical considerations of maternal and fetal bodies. Now, just side note, Professor Schoen's books are fantastic, and I encourage you all to read them. And as you can tell, likely from the titles, they provide critical perspective on reproductive health issues that are all too timely. And just another tidbit from Professor Schoen's biography is that as a historian, her research has had impact beyond just the walls of academia. For example, in 2002, she shared with a journalist her research on the history of eugenic sterilization in North Carolina. And the state's sterilization program had run from the 1920s to the 1930s and led to, 1970s, and led to the sterilization of more than 7,000 people. And the Winston-Salem Journal then ran a series of articles on the subject, which ultimately resulted in an official apology from the governor of North Carolina. So I think that's really significant. And that's just one example of how impactful Professor Schoen's research has been. Professor Schoen is now working on a book, Life and Death in the Nursery, on the history of neonatal intensive care units, for which she received a 3-year research grant from the National Institutes of Health, National Library of Medicine, which the Trump administration has forgotten to take away. See, like that. Hopefully, that continues to be the case. And then in her spare time, Professor Schoen volunteers at Memorial Sloan Kettering Cancer Center, where she is emeritus co-chair of the Patient and Family Advisory Council and works on improving end-of-life conversations between clinicians, patients, and caregivers. And today, Professor Schoen is speaking to us about innovation and moral distress in the history of neonatology. Welcome.
Thank you so much, both for the lovely invitation and the lovely introduction. I really appreciate it. It's a pleasure to be here. And I'm really glad that you all found the room and know that you can take a lunch to reward yourself for finding the room. So thank you. I'm just going to start. I will say that the talk that I'm going to present, because it's on moral distress, is a talk and a quarter talk, because part of it also has to do with a history of lack of pain control in anesthesiology, in neonatology, but I guess it'll be obvious. So in January of, hold on. That was the wrong button. No, that's too far. No, this goes. In January of 1945, a young Bill Silverman was on the house staff at Baby's Hospital in New York City when a premature infant born at 5.5 months gestation and weighing 620 grams was transferred to the 4-bed premature nursery. I had never seen a baby this small. Silverman, considered the father of neonatology, remembered in the early 1990s. As I learned later, no infant of this size had ever lived for more than a few hours, at our institution. Silverman recalled his enthusiasm with which he approached the infant that had been thrust into his inexperienced hands. He looked up Levine and Gordon's how-to article published in 1942 and kept their instructions next to the incubator. With one exception, he explained, I followed their instruction as a cook follows a recipe. As advised, I stabilized fluctuations of body temperature and made no effort to warm the infant anywhere near 37 degrees Celsius. I prescribed continuous oxygen, and I gave subcutaneous Clysis twice a day until gavage feedings of a low-fat, high-protein formula were sufficient to sustain weight gain. My one deviation was a novel treatment for recurrent episodes of apnea and cyanosis. I came across a suggestion that a defect in blood gas transfer might be the result of low levels of carbonic anhydrase in the blood of prematurely born infants. The handicap might be overcome, it was theorized, by small blood transfusions of adult whole blood. This optimistic suggestion of an untried treatment was just the kind of bold action I was looking for. I began to transfuse the infant daily with a few milliliters of my own blood. I quickly became convinced that it was my carbonic anhydrase-rich blood that was keeping the baby alive, and I was not unmindful of the fact that she was setting a new hospital record for longevity. I was made to feel like a hero. My rescue fantasy was fulfilled. To his great disappointment, the infant's parents did not share Silverman's joyous feelings of high adventure. In their late 40s with 2 grown children, they were completely overwhelmed by Silverman's attempts to prolong the life of their unplanned and unwanted infant. I tried to focus their attention on the miraculous present, and I was annoyed that their thoughts were fixed on an uncertain future, Silverman remembers. They kept asking about long-term outlook. I was forced to admit that I had no idea about prognosis because few, if any, infants of this size ever survived. The longer the baby lived, the more angry the parents became at the thought that I, a young childless house officer with no personal experience in rearing a normal child, much less one who might be disabled, now held in my hands an important determinant in the fate of this family. And it was quite clear to them that I was not accountable for the social, to say nothing of the financial consequences of my actions. The infant Silverman treated in the mid-1940s more than tripled her birth weight, but after 3.5 months died. Looking back at these events in the early 1990s, Silverman criticized his moral reasoning at the time of his rescue efforts. Almost 5 decades later, he found his thinking based on the morality of law and duty to the social order inferior to the moral judgment of the parents. Their outlook, he argued, focused on the larger social outcome of medical efforts and sought to balance competing interests rather than narrowly focusing on the fate of the individual infant. 2 his decades as a practicing neonatologist taught him that parents feared overtreatment. Worried the outcome of his efforts would lead to the survival of a severely compromised child, many parents had told him not to try too hard to keep their premature infants alive, but to give them another chance at having a normal baby, a sentiment he began to share when he and his wife began to have children of their own. As my social experience grew, he noted, so did my moral ambiguity. In his evaluation of neonatology decades later, Silverman criticized his clinical enthusiasm with which he and his colleagues approached resuscitation and treatment of extremely premature infants, as well as the lack of research to evaluate widely used and long accepted treatments, many of which turned out dangerously wrong. The 12-year use of high-concentration oxygen, which was eventually found to be responsible for blinding thousands of infants, the belief held for 25 years that very small infants could control their own body temperature until controlled trials demonstrated the fatal consequences of even small decreases in body temperature, the feeding of low-fat, high-protein milk that turned out to adversely affect infants' cognitive development. I want to take the opportunity today to look at 2 clinical interventions, resuscitation and pain control, to tease out the ethical implications they have held for clinicians parents, and infant patients. I have chosen those two because they raise a number of medical ethics questions that I think we need to keep at the forefront of our thinking as we contemplate the history of neonatology and the lessons we can draw from it going forward. Interventions in the delivery room in premature infant nurseries began to escalate with the introduction of the ABGAR score in the 1950s. Virginia ABGAR initially developed this score to assess the impact different forms of maternal anesthesia administered during labor and delivery had on the newborn. The newborns she observed in the delivery room, often lethargic and in distress from the anesthesia the mothers had received, were frequently left unattended for long periods of time. ABGAR began to resuscitate them. Over the following decade, ABGAR and her colleagues developed and published detailed guidelines, including a training film about when and how to resuscitate infants. Use of the score spread quickly and widely as it became established procedure in delivery rooms from Moscow to Stockholm and Ottawa to Sydney. While certainly not calling for drastic resuscitation methods, the ABGAR score with its attendant call for action led in the mid-1950s to dramatic actions at Baby's Hospital. As Silverman remembers, a new chief of obstetric anesthesiology was called to be present at the delivery of an extremely small baby at about 23 weeks of gestation and weighing roughly 500 grams. The neonate did not breathe spontaneously and had no pulse. The new anesthetist asked for a scalpel, opened the chest with one stroke, and began to squeeze the heart directly as he yelled for someone to intubate the baby immediately. No one prior to this had ever dreamt of using open chest cardiac massage for resuscitation of the newborn. Needless to say, the incident had an electrifying effect on the crowd of open-mouthed young people in the room. This was a very loud signal indicating how far resuscitative efforts were now prepared to go. The fact that the neonate died a few hours later was dismissed as an irrelevant detail. Although I was horrified by this act, I had to admit it differed very little from my Never Say Die action 10 years earlier. The development of the ABGAR score coincided with the establishment of the first neonatal intensive care units. In 1960, pediatrician Louis Gluck expanded the existing 9-incubator premature nursery at Yale into a newborn special care unit, and the following year, neonatologist Mildred Stallman established a neonatal intensive care unit at Nashville's Vanderbilt University Medical Center. In other medical centers, too, physicians began to experiment with the idea of neonatal intensive care. Hospitals in London, Toronto, Montreal, Stanford, Boston, the University of Pennsylvania, the University of Colorado, the University of California at San Francisco, University of Southern California, and Johns Hopkins University all established NICUs in the early 1960s. With the development of the ABGAR score and the establishment of NICUs, the treatment of premature and critically ill newborns changed from a philosophy of handling infants as little as possible to one of aggressive treatment. Within a decade, neonatology grew into a clinical subspecialty able to save infants who would have died earlier. But these gains came at a cost, as the number of infants who survived with significant medical problems rose substantially. As the establishment of clinical centers devoted to the care of premature and sick infants increased, the number of infant patients, as well as the clinical problems with which infants presented, it also led to disagreements between physicians and parents over appropriate treatment options. Today, I will not go into the details of the debate. Suffice it to say, starting in the early 1970s and with increasing intensity in the 1980s, clinicians debated amongst each other when to treat, when not to treat, and when to withdraw treatment. The parameters and positions in this debate changed as treatment got more sophisticated and the outlook of infants, particularly those with congenital anomalies such as trisomy 21 and myelomeningocele, improved. The experience of Peggy and Robert Stinson well illustrates the suffering and chronic grief that could accompany neonatal care by the 1970s. On December 17, 1976, Peggy Stinson gave birth to their son Andrew at a community hospital in Bethlehem, Pennsylvania. At 800 grams and a gestational age of 24.5 weeks, Andrew was not expected to survive. Peggy and Robert asked the medical staff at community hospital that no heroic efforts be made to extend his life. Against their wishes, hospital staff transferred Andrew a week after his birth to the NICU at Children's Hospital in Philadelphia, where he was placed on a respirator. Over the next 5 months, he became, in the words of his parents, hopelessly entrapped in an intensive care unit where the machinery was more sophisticated than the code of law and ethics governing its use. As a result of the treatments he received trying to keep him alive, Andrew developed a range of complications. Placed on the respirator, he developed bronchopulmonary dysplasia as well as retrolental fibroplasia. The chronic lung problems, in turn, led to a slowing of Andrew's heart rate and a lack of oxygen in his blood. Unable to meet his nutritional needs, in particular his needs for minerals, he suffered multiple bone fractures. As Andrew's lungs became irreparably diseased, he developed high blood pressure and began to have seizures. When on June 10th, Andrew dislodged the tube connecting him to the respirator, CHOP's physicians decided not to reconnect him. He finally died on June 14th, 1977. As his parents sarcastically noted, he was in effect saved by the respirator to die 5 long, painful, and expensive months later of the respirator's side effects. Devastated and furious, Peggy and Robert Stinson wrote a letter to CHOP's administrators and personnel, sharply criticizing the aggressive treatment of Andrew. The story of Andrew's short, cruel, institutionalized life, they warned, is a case study in the limits and excesses of modern medicine. In 1979, they published a book, The Long Dying of Baby Andrew, about the ordeal. In addition, they published an abridged version of their letter to the hospital in Atlantic Monthly and in 1981 in the Journal of Medical Ethics. Andrew Stinson's case was far from exceptional. Parents across the country found that neonatologists ignored their wishes to allow their severely ill infants to die, instead resorting to coercion, threats, and court orders to treat the infants only to have them die months or even years after gruesome medical ordeals. The Stinson's complaints were followed a couple years later by similar charges from California couple John and Susan West, who in October 1980 gave birth to their son Brian. Brian was diagnosed with trisomy 21, a missing esophagus, and a heart murmur. The attending physician described how the particular combination of Brian's defects were far more serious than either one would have been alone. His missing esophagus could be surgically reconstructed, but Brian would never be able to swallow normally and would constantly be in danger of choking on his food. Since trisomy 21 was associated with poor muscle tone, this further increased Brian's chances of choking. In addition, stomach acids would back up into his reconstructed esophagus, and since children with trisomy 21 are also overly susceptible to upper respiratory infections, without a properly functioning esophagus to drain normal secretions to the stomach, these fluids would back up into the lungs and cause pneumonia. Finally, physical therapists warned that the reduced mental capacity of children with trisomy 21 might defeat the therapeutic process required to learn how to use the new esophagus, and that Brian's frequent hospitalizations and surgical interventions would mean that attempts at early intervention and stimulation so crucial for children with trisomy 21 would be frustrated, indeed might significantly set Brian back. Doubting that the long-range outcome for Brian would be good, the Wests refused to authorize the surgical repair of Brian's esophagus. The decision, John West remembers, was based on love and on the golden rule. Had they been in Brian's place, neither he nor his wife would have wanted to be kept alive. The hospital's doctors and administrators, however, disagreed with the West's refusal to consent to Brian's surgery and asked the state to bring charges under the state's child abuse laws against the West. The West were charged with willful neglect, and Brian was removed from their custody and placed under the guardianship of the state. Susan West recalled, "We watched helplessly as our baby endured multiple surgeries and a host of chronic, painful maladies. Brian spent the initial months of his life attached to a nasal suction machine and was fed by a hose through a hole in his stomach. Infections became chronic. Reconstructive surgery on the esophagus was performed in 2 stages after he was a little over a year old." And I have to add to that Susan West told me that the surgeon told her that she had never done a surgery like that and that she was excited about doing the surgery because it was new and novel and she wanted to try to see if she could do this. But as I said, the surgery failed. Reconstructive surgery, the process can only be described as hell for Brian. The wounds failed to heal properly, stomach acids backed up continuously, causing such pain and irritation that it became necessary to restrain the baby's hands and feet by tying them to the 4 corners of the crib. His new esophagus was never functional, and he became caught in a perpetual pilgrimage from nursing home to hospital and back again. Shortly after his 2nd birthday, in October 1982, another infection of unknown origin sent him to the hospital once again. While there, he went into respiratory shock and was placed unconscious on a respirator. When he stabilized, he was severely brain damaged, blind, bleeding internally, experiencing intermittent kidney failure, and had an overwhelming infection throughout his body. On December 21, 1982, at 26 months of age and weighing only 14 pounds, half the average weight of a 2-year-old, Brian James West finally died. 5 days later, John and Susan West appeared on CBS's 60 Minutes to talk about their experience. Neonatologists' willingness to consider parents' requests against aggressive care declined further in the early 1980s after President Ronald Reagan, prompted by outcries of his right to life constituents, passed so-called baby dough regulations, which threatened hospitals with a loss of federal funds if they withheld medical treatment or nourishment from handicapped newborns. To facilitate whistleblowers' reports of alleged violations, the administration established a toll-free 24-hour handicapped infant hotline with a number prominently displayed in delivery rooms and pediatric wards. 2 years later, the regulations were added as an amendment to the Child Abuse and Neglect Prevention and Treatment Act, which made withholding medical treatment a reportable act of neglect and abuse. By 1987, Child Protective Services had received 41 complaints and intervened in 11 cases, affecting a change in treatment decisions always in favor of treatment in 10 of these. Just as pro-lifers can stop abortion clinics, one neonatologist lamented, baby dough has made it withdrawing treatment that much harder for us. The outcry of parents against aggressive neonatal care led to the first hospital-based parent support groups, and in 1982, the establishment of an international parent support organization, Parent Care for Parents of High-Risk Infants. One of the founders, hold on, this is not keeping up. There. One of the founders of Parent Care was NICU parent-turned-health activist Helen Harrison. Harrison had earned a degree in Slavic languages from the University of California at Berkeley and worked as a Russian to English translator and as a medical and laboratory technician with the Berkeley Community Health Project when she gave birth to her son Edward in 1975. 3 months premature and suffering from listeriosis, a serious bacterial infection, Edward was not expected to live. When physicians took him off the respirator to allow him to die, however, Edward defied all expectations and continued to breathe. At that point, the NICU staff jumped into action and vigorously supported Edward who survived with multiple disabilities, including hydrocephalus, a serious neurological disorder caused by the abnormal buildup of spinal fluid in the brain, and severe intellectual disabilities. While Harrison had a positive view of the NICU, this changed in the late 1970s and early 1980s when she began to interview parents about their experiences with neonatal intensive care units to write a guidebook for parents who experienced the birth of a critically ill premature baby. In 1983, she published the Premature Baby Book and became one of the founders of Parent Care, an international support organization for parents of high-risk infants. I have to say, I always think of the Premature Baby Book, this is for those of you who are my generation and a tad younger, as the equivalent of Our Bodies, Ourselves. I find that my younger students no longer know what that is, but it is really the Bible of, and it really pulls a community together when it comes out. In October of 1984, Parent Care held its first annual conference in Salt Lake City. Parents criticized the research and teaching interests that led clinicians to resuscitate and pursue aggressive treatments for even the most fragile infants. Neonatologists and pediatric surgeons, parents charged, were more concerned with pushing back the frontiers of their subspecialty and envisioned premature infants as a new population for heart, bowel, and brain surgery. Clinicians' need for knowledge and skills, Harrison argued, should not override humanitarian considerations whether or not to resuscitate and treat extremely premature infants. Harrison also had sharp words for the Reagan administration's political interference in the practice of neonatology, noting that neonatologists she had interviewed had told her that their decision-making was based less on their perceptions of child and family interests than on their need to practice defensive medicine. She argued these physicians feared professional, public, or legal harassment if they made a decision that could be construed as out of strict compliance with the law. Contradictory court rulings, as well as the ever-changing baby door rules, have made neonatologists understandably nervous. The safe way out is to order maximum treatment in every case. Reflecting on the cases of Andrew Stimson and Brian West, Harrison concluded, despite widespread public and professional support for a parental role in decision-making, parents are essentially at the mercy of the philosophies and motives of their physicians. A lack of anesthesia and consistent pain control administered in the NICU throughout the country further aggravated parents concerned with the level of distress infant patients experienced. On February 24, 1985, 17-day-old Jeffrey Lawson, born at 760 grams and 25 to 26 weeks gestation, had surgery for a ductus ligation. Jeffrey's neonatologist, John Scanlon, had referred Jeffrey, who was born at Columbia Hospital for Women in Washington, D.C., to Children's Hospital National Medical Center for the surgery. There, an incision was made in his chest, circling his left side from breastbone to backbone. His ribs were pried apart, his lung lifted up, and his ductus was ligated. A second incision was made in his left side to accommodate a chest tube. 3 additional incisions in his neck and chest were needed for the insertion of a Bovia catheter. This procedure proved difficult and had to be repeated. Jeffrey was in surgery for a total of 90 minutes. He returned to the nursery in a state of deterioration from which he never fully recovered. He died 5 weeks later. After Jeffrey's death, Mrs. Lawson received his chart and discovered that at no time before, during, or after surgery had her son been given anesthesia or pain relief of any kind. Instead, Jeffrey had been paralyzed with Pavulin, a drug that left him unable to move or react in any way, but fully conscious and able to feel everything that happened during his hour and a half on the operating table. Horrified, Jill Lawson raised alarm and complaint. Jeffrey's anesthesiologist explained to Jill Lawson that it had never been demonstrated that premature babies feel pain, and because anesthesia was considered risky for tiny unstable babies, she had chosen not to anesthetize Jeffrey. Jeffrey's surgeon told Lawson that since the anesthesiologist never told him about her decision not to anesthetize Jeffrey, he did not know he had operated on an unanesthetized baby. The chief of anesthesiologists at National told Lawson that the pain of a ductus ligation was comparable to that of intubation, and that Jeffrey's own beta endorphins should have taken care of any momentary discomfort. And a senior neonatologist, also the editor of a major neonatology textbook, told Lawson that her baby was a fetus who could not feel any pain, and indeed that babies didn't feel any pain until they were 2 years of age. Others to whom Lawson turned for help suggested that she seek psychiatric counseling to address what they considered her inappropriate grief responses. Lawson appealed to more than 40 medical organizations and advocacy groups, including various local medical regulatory boards and child protection agencies, the AMA, the anesthesia section of the American Academy for Pediatrics, the American Society of Anesthesiologists, the American Board of Anesthesiology, the Hastings Center, the Kennedy Institute of Ethics, the Baby Doe Unit at the Department of Justice, Child Protective Services, the Children's Defense Fund, the National Perinatal Association, the list goes on. All failed to respond, declined to become involved, or supported the anesthesiologist. Others in the medical community, however, validated Lawson's concerns. Jeffrey's neonatologist John Scanlon had regularly referred infants for surgery to National, unaware that the infants did not receive anesthesia. Outraged, he wrote an article about the incident entitled Medical Barbarism, which appeared in Newsday and Perinatal Press. The editor of the journal Birth, too, published an editorial about the case, and both Birth and Perinatal Press printed letters from parents, including Lawson and Harrison, thus offering the first forums for the discussion of unanesthetized infant surgery and allowing concerned parents, clinicians, and ethicists to connect with each other. So Lawson and Harrison, for instance, both get to know each other because they both have letters in Birth, and then Scanlon introduces them to each other. 10 years ago, Harrison wrote in her letter to the editor, "Our prematurely born son, Edward, was shunted for hydrocephalus while paralyzed with Curie. Although he could not move, cry, or react in any way, he could see, hear, and feel as large incisions were cut in his scalp, neck, and abdomen, as a hole was drilled in his skull, as a tube was inserted into the center of his brain, then pushed down under the skin of his neck, chest, and abdomen, and implanted deep in his abdominal cavity." When in August of 1986, the Washington Post published an article on the Lawson case, the mainstream press finally picked up the story. Reprinted around the country, the Washington Post article was followed by 16 additional articles and TV appearances, and the story made it around the country. And as the story made it around the country, parents realized with horror that their infants too had not received anesthesia or pain control during major surgical procedures. And I will just remind you here that all the stories that I was talking about before, including Brian West and Andrew Stinson, probably also didn't have anesthesia as they were going through their surgeries and other procedures. In Oakland, California, Jacob Eli Schwab, born at 23 weeks gestation, had had abdominal surgery at Children's Hospital on the 17th day of his life after he developed necrotizing enterocolitis. Jacob's parents had been told during the pre-op consultation that Jacob would receive medication to relieve his pain, but after requesting Jacob's medical records, they discovered that he had only received a muscle relaxant. He died the day after the surgery. Horrified, Jacob's parents described the surgery without anesthesia as appalling and barbaric. In Florida, Carmen Mercado, born in 1983 at 28 weeks gestation, had 4 brain surgeries without anesthesia. When her mother, Linda Mercado, refused consent for her daughter's surgery after she learned the surgery would be performed without anesthesia, she was reported to Child Protective Services as an abusive parent. And in Ohio, Bart Dasher's premature son, Keith, had heart surgery without anesthesia. Journalists reporting on these cases illustrated the prevalence of the practice, and parent advocates had begun to reach a national audience. Through the 1980s and 90s, parents discussed a wide array of painful medical procedures their children had been subjected to. I had long wondered how an infant can differentiate between pain or abuse that is medically necessary and abuse at the hands of an out-of-control parent or caretaker, one parent noted. It is generally acknowledged that abused infants become emotionally scarred. No one says they will be fine because they can't remember, yet the myth remains that NICU veterans forget. For many NICU graduates, the NICU was only the beginning of years of medical treatments they had to endure. Infants who had received shunts for hydrocephalus, for instance, could face many surgeries for shunt revisions as they outgrew their shunts or as the shunts became infected. Many children experienced these procedures as painful and traumatic. Parents were also outraged at their lack of legal redress. One Florida mother, the one who was reported to Child Protective Services as an abusive parent when she refused to consent to her daughter's surgery after learning the surgery would be conducted without anesthesia. Since withholding anesthesia from infants fell within the standard of practice, and since physicians were presumed to be acting in the child's best interest, the child abuse laws applied only to parents. Convinced that neonates did not experience pain, neonatology textbooks and medical journals did not discuss infant pain. There were no articles on neonatal pain published in 1977, and only one each in 1965, 74, 75, and 76. Alarmed by the media campaign about unanesthetized infant surgery, in 1987, so a year after the Washington Post article basically makes all of this public, the American Academy of Pediatrics surveyed hospitals about the practice and found unanesthetized infant surgery was, quote, not uncommon. An anesthesiologist familiar with the survey characterized the findings as appalling. Unanesthetized surgery for infants up to 15 months of age was the rule rather than the exception. In fact, 80% of ductus operations, one clinician found, had been performed with little or no anesthesia. That fall, the AAP issued a statement recommending the use of analgesia and anesthesia for neonates. And while the American Society for Anesthesiologists voted at their October 87 meeting not to endorse the AAP statement on neonatal anesthesia, by December, the ASA gave the statement their stamp of approval as well. Over the following months, Lawson, Helen Harrison, and bioethicist Nance Cunningham Butler interviewed clinicians around the country to determine how frequently clinicians ignored infant pain. They found beliefs about infant pain to be varied and contradictory. While some physicians noted that their years of experience convinced them that babies felt pain just as acutely as adults, others claimed that their years of bedside experience convinced them that babies did not feel much pain. Still others claimed that it was irrelevant whether or not babies felt pain since they couldn't remember the experience. Yet others pointed to evidence in the literature that neonatal pain could have lasting detrimental physiological effects and claimed that not offering pain control was unethical. For those who acknowledged that babies felt pain, what they chose to do about it varied as well. Some maintained that it was unethical to give pain relief until well-controlled studies with long-term follow-up demonstrated the safety of pain medication and anesthesia. Others, by contrast, pointed out that virtually nothing done to babies in the NICU had been subjected to such studies, and that neonatologists on a daily basis used agents with far more serious side effects for far less obvious reasons than the relief of severe pain. Harrison, Lawson, and Butler noted in particular the double standard toward humanitarian considerations in favor of pain control. Pain relievers were also risky for adult patients, they pointed out. Yet when physicians made risk-benefit calculations for verbal patients, humanitarian considerations in favor of pain control were given considerably more weight. Parents also criticized their exclusion from medical decision-making, and they objected to the lack of attention paid to the suffering of neonates, as well as the impact of aggressive treatment on families, as the parents continued Where is the description of the months and years of grueling hospitalizations with the associated gastrostomy tubes, jejunostomy tubes, and fundoplications, the tracheostomies, shunts, and orthopedic eye and brain surgeries, hyperelimination, oxygen tanks, and ventilators? Similarly, there was no mention of bankruptcies, divorces, mental and physical breakdowns, deaths in childhood, neglected siblings, and suicide caused by the extreme burdens of caring for severely medically and developmentally compromised children. But parents were not the only ones who found the treatment of their premature infants unsettling. Clinicians, too, reported being disturbed by the realities of aggressive treatment, even if they found it difficult to change their decision-making. Seeking to improve decision-making about resuscitation, for instance, a handful of clinicians began in the late 1980s to analyze the process that led to decisions about resuscitation. Two clinicians from Stanford criticized the institution's approach to trying to save every neonate, which they argued completely ignored the suffering endured by many of the premature infants. In any setting other than an intensive care unit, a daily routine that involved restraining neonates in bed, placing plastic tubes into various body orifices, and pricking the feet with needles would be considered torture. The suffering that the neonates endure during the course of the care they receive must be considered further. While conceding that perceptions of suffering were highly variable and subject to interpretation, they cautioned that just because suffering is difficult to conceptualize does not justify assigning it a weight of 0 in a decision-making algorithm. To do so results in a dehumanization of those neonates who experience suffering. Rather than setting weight or gestational age limits for resuscitation, however, the Stanford clinicians recommended that resuscitation decisions should be made based on individual prognostic strategy. Clinicians should start treatment and then reevaluate the infant based on clinical indications, with the option of withdrawing treatment if the infant was in a class where the outcome was grim. These debates, however, failed to resolve the ethical issues surrounding treatment decisions or to change treatment practices. Indeed, with the introduction of surfactant and steroids in the 1990s, many neonatologists resisted parental choice in any area of neonatal care in hopes that the short-term improvements they were seeing from the use of these drugs would translate into better outcomes even in the most immature infants. Unfortunately, outcome studies of the steroid and surfactant era showed no improvements in long-term developmental outcomes, while some studies revealed deteriorating outcomes. Interviews with physicians in the late 1990s found that despite awareness of the high morbidity and mortality, 96% of physicians offered resuscitation to all extremely low birth weight infants in the delivery room. The main factor affecting their decision were the role of the physician, having been trained to save lives, the belief that if called, I resuscitate, the inability to determine gestational age, requests from parents to do everything, and the need to move from a chaotic delivery room to a controlled neonatal intensive care unit. Since resuscitation criteria were not addressed during medical school or fellowships, physicians were not taught how to discern who should and should not be resuscitated. Many experienced no alternative model other than full resuscitation in the delivery room. There's no one telling you the rules because there aren't any rules, one young neonatologist noted. 2, the inability to predict which neonate would survive prompted the decision to resuscitate all extremely low birth weight neonates. We always hope that this particular case won't be bad. This particular case will shine. This will be the one that all the bad things don't happen to, another clinician commented. Many were disturbed that with the new technology, infants for whom treatment was withdrawn no longer died in 2 or 3 days. Instead, it often took 2 weeks for them to die. It's prolonged, one clinician noted. Then the family gets attached and you get on the treatment train. And once you get on the treatment train, it is extremely hard to get off. As a result, clinicians experienced a high degree of burden and internal conflict. You see so many people suffer, one of them noted. You see the children suffer, you see the families You see the nurses and everybody that works there go through this over and over again, and you get so tired of death. You get so tired of disability and chronic handicaps. And another observed, I just agonize over some of them all the time. You're sorry for what you did, but you don't know what you would have changed or how you would have decided differently or where you could have gotten off, whether the parents would agree with you or not, whether you're making the decisions for the right reasons. Nurses too experience distress and moral ambivalence about the treatment of neonates they deem too premature or too sick. There was frustration at physicians who made decisions without properly educating parents and wondered how to make ethically sound decisions in an environment where the technical capabilities now enable clinicians to sustain infants born at the edge of viability while doing increasing harm. Chest tubes, multiple epidoses, surgery, and full codes is going beyond what is considered viable, and the parents should be told this, one nurse commented. Sometimes I feel like we're in this contest to see how young we can go. Indeed, by the late 1990s, aggressive treatment increasingly took place at the behest of parents who had conceived through IVF and now asked that everything be done for their neonates, even when chances for intact survival were slim. For the past decade, cultural shifts have led to increased parental optimism in NICU technology, making it much more likely that parents, rather than clinicians, push for aggressive treatment. As one nurse explained, when parents hear a 0 to 10 survival rate, they cling to the 10% and have no idea what that actually means in terms of pain and suffering, both short-term and possibly for the rest of the child's life. It often seems that when we resuscitate these edge of viability infants, it is to please the parents, especially in the IVF environment that we have today. The concern is not for the comfort of the infant. The concern is to give the parents their child no matter what. I think parents are giving false hope. In the end, the relentless protest of parents and support from clinicians led to changes in clinical practice. By the late 1980s, clinicians demonstrated that infants and children did indeed experience pain and that the administration of anesthetics significantly reduced infant stress during surgical procedures. And if 80% of clinicians failed to regularly administer anesthetics and analgesia when performing painful procedures to neonates, 20% did address neonatal pain. These neonatologists, anesthesiologists, and nurses pushed their colleagues and trained their residents to take neonatal pain seriously. By the 1990s, clinicians offered guidelines for pediatric pain management, including details about recognizing and assessing neonatal pain and medication dosages for neonates. Still, NICUs varied widely in their use of pain medication for neonates, and it took until the late 1990s for appropriate pain control and anesthesia to become routine in NICU care around the country. The formal adoption of palliative care options in the early 2000s offered parents and clinicians a more structured alternative to aggressive neonatal care. Over the decades, as increased use of IVF changed parental investment in pregnancies, parents also became, as I said earlier, more likely to push for more rather than less treatment of their premature infants. Neonatal technology has made great strides since the 1970s. Complications of prematurity in infants over 28 weeks have declined dramatically. Historically, there has been a lot of suffering involved in bringing about NICU care we take for granted today, both among infants and among parents. Neonatologists have learned the hard way to respect parents' agency at the bedside and in planning clinical trials. And parents too have changed. As outcomes for NICU graduates have improved, many parents have now adjusted to caring for children who emerge from the NICU in fragile health and with a range of disabilities. Indeed, recent studies from the Canadian Parents' Voice Project have illustrated that parental assessment of their children's abilities seem much more optimistic than clinicians' assessment of NICU babies. In particular, researchers have noted that the categories and scales clinicians employ to rate impairment hold little meaning to parents who in turn focus on their child's function, development, and achievements. Regardless of impairment, the researchers concluded, parents tended to rate their child's overall health high. When parents are asked in their own words what is important, they prioritize function over diagnosis, one researcher concluded. Of course, drastic funding cuts under our current administration has compromised the level of support to individuals with disabilities. This means that American parents' ability to adjust and find help as they care for disabled NICU graduates might not match that of their Canadian neighbors. American parents then are more likely to suffer from emotional and financial stress related to raising severely compromised infants. It is important that clinicians continue to press for political support for families whose children emerge from the NICU with long-term care needs. Thank you. And I'm sorry that was a little longer than that.
Thank you. That was really wonderful and really gives us a lot to think about. I mean, this raises a lot of critical issues, ethical issues, and historical issues. So the floor is open for questions. So if anyone has one? Yes.
The narrative you tell about this interesting transition from these early horrifying days of parents really pushing back against doctors' intervention.
Yeah.
And then at some point, as you sort of say in the 21st century, that the role reversal.
Yeah.
And there's more parents pushing and doctors wanting to. And you mentioned a little bit about IVF. Now, I'm just curious more about how that transition happened. And do you think it is unique to the NICU, or is this happening across healthcare?
What a great question. I love that, which also means I can immediately answer it. I mean, oh, that is such an interesting question. I do think a couple of things happened. So first, to talk about the transition with IVF babies. I don't know as much about it yet as I want to know. What I do know is there is a clear change. I think neonatologists at some points actually understand that they do have to listen to parents and that they really do have to inform them better and take parents' advice into consideration. So I think to a certain extent, the baby doe rules that I talk about under the Reagan administration, what happens is that they lead to a sharpening of the situation and a fighting it out between the different camps in a way, right? So the parents who complained in the 2000s about the fact that they haven't been taken seriously, of course, delivered and experienced NICU care in the 20th century and not in the 21st century. And I think that is also the part where it begins to change. And then clearly with IVF, one of the things that happens is that parents become so much more invested in pregnancies. I mean, these are parents who have gone through years of, infertility, of miscarriages, and now they're finally pregnant and they're delivering. And their attitude towards what they want, that they want this infant, is so different from the parents that Silverman describes, who beg him not to do so much because they want to just try to have a normal child. So it's just a different group of parents also that we're talking about. So there's that shift, I think, that is super important, along with the fact that neonatologists are now more careful to draw parents in. But I also feel that there is a love and an overpromising of the technology. And I think that is not particular to the NICU. So I think back, for instance, to all the debates we had about ventilators during COVID. And the fact that I think people don't really understand what it means to be long-term on a ventilator. And they see these TV shows of somebody on a ventilator, and then they get up and they walk out of the hospital. And we all know that that's not really what happens, right? So I think part of it has to do with this kind of love relationship that we have with medical technology. That also means that we overinvested and think that it can do much more than it promises. And that for most people, there's a lack of understanding, both of what it feels to be on the machines and then also what the long-term outcomes are. And interestingly, I think also a lack of really wanting to learn about it. So one of the things that parents push for in the 20th century is really they want to have educational lessons for parents who are pregnant, for people who are pregnant, and they want a discussion about this is what could happen to your infant. Of course, nobody wants to have those discussions, right? Obstetricians don't want to do them, and parents don't want to hear these kinds of things. And so I think to a certain extent, even the things that the parents push for and that eventually do become a reality don't really turn out the way that they had hoped. And so in some ways, to me, it's also a really interesting lesson on patient activism and what happens when patients are actually able to achieve something that changes clinical care, but the outcome is not necessarily what the activists had hoped. That's a very long, wandering answer to it. Yeah.
Thank you. That was a really wonderful presentation. I take a lot away from that. As an former NICU nurse, I have always been floored by the fact that there was a previous understanding that neonates didn't experience pain. I don't know how you miss it. Taking care of me. I don't know how you miss pain.
Yeah.
I just, regardless of size, 485 grams to thousands of grams. So that's always really interesting to me. So my question though goes to the current situation where parents and health institutions are much more involved in shared decision making.
Yeah.
But it is true that I think a lot of parents are their gut instinct is to do everything.
Yeah.
And there is, I believe, a remnant of the baby doe laws in capitulating to that.
Yeah.
So you think it might be really a long shot for success. And I think that might be that is one setup for moral distress amongst healthcare providers.
Yeah.
How that we're.
I think that's right. And I think the nurse hinted at that, right? That quote that I have that she says the parents cling to the 10%, but they don't really understand and they're not really well enough educated.
Yeah. Yeah. So what are your next steps in terms of incorporating moral distress into this kind of historical picture, or do you have next steps in terms of incorporation?
So I have the pain talk is really a separate talk. I folded it in because it needed to be in here, but I have a whole talk that's only on pain. It's not on aggressive care. And that is actually super interesting. And so I'm actually really glad you're telling me the story. In fact, I might need your contact information. I always rely on people coming from the NICU space to my talks. And because what happens, I didn't talk about that here, but what happens in the 90s as this debate continues is it really becomes a debate about language and how do you define pain rather than anything else. And I think really what the people who are continuing to say we can't change our position on pain and we don't need to anesthetize these infants do is they're trying to hold up a whole clinical system. And they're also trying to hold up, I think for clinicians, it's at the very least embarrassing, if not, really scandalous. So what it means is you have to question your entire training and practice in order to change your ways. So I'm partly interested in that. I don't know yet. So I gave this talk a couple of weeks ago at Duke in a symposium on the artificial womb, because we're now starting on artificial wombs for infants. And there was one neonatologist who told me afterwards, I think he didn't like the talk, but whatever, who told me afterwards that now we're over pain medication, giving too much pain medication, and all these infants are, basically they're too asleep and not really aware of what happens and all these kinds of things. And I have to say, that is really part of the nature of individual NICUs. It's not part of the system, but it really means that each neonatal intensive care unit has to figure out itself what they feel is an ethical way of dealing with this question, also of dealing with this question of when and how do you introduce, for instance, the option of palliative care, which I think is also important. I think the next thing I need to do is first chronicle the introduction of palliative care in the NICU, which happens in the 21st century. And I have that material. I just haven't had time to work through it yet. And then I want to double back and kind of see, yes, what does that mean? And I am super interested in the moral distress that clinicians, nursing staff, but also neonatologists today feel at overtreatment that parents want. But of course, that also happens in other ICUs, when people want to have no DNR orders and all kinds of other things, want interventions, when really what is happening is that they're dying. I don't know if that's an answer to your question at all. Okay.
Sure. We have any questions from online on the north side, but we have two questions from Zoom to convey. One is someone wanting to know the origin of the theory that preemies
don't feel pain.
How did that last so long?
Yeah.
And then a second question about your thoughts on increasingly recognized issues of neonatology, like the wide use of off-label therapies and emerging use of AI, machine learning for monitoring, and how we might pass on some of these lessons to these sort of ongoing present day.
Yeah. So the history of the pain issue is basically what happens is, of course, you can't do most of these surgeries for the longest time period, right? So it isn't really an issue until we get to the creation of Neonatal Intensive Care Units and then the development of the surgeries and the fine-tuning of the surgeries. The idea that neonates don't feel pain basically comes from the post-war era. And there were a couple of studies. One of the problems was that anesthesia in the immediate post-war years were basically given with a funnel, and you couldn't really control how much ether infants got, and so they would get too much and they would die. Or they would suffer cardiac arrest or other problems. And then there was a parallel studies at the same time period that a nurse did, and she basically swaddled infants, and she did like pinprick things on their feet, and decided that if they were swaddled, they didn't feel pain. And so those two beliefs, the impossibility of figuring out how to give adequate anesthesia, and this idea from this nursing study that these infants didn't feel pain, kind of merged. And so that's kind of where all of this traces back, at least to the post-war era.
Do we have time to?
Yeah.
Yes. Yeah. Well, I do want more then.
Yeah. And so the reason when I talk about how all the textbooks don't even address pain and there's no publication on pain in infants kind of traces back to that. And that really only changes in the mid-1980s after that Washington Post article. There are a couple of people who are at that point starting to work on pain on neonates because, as you rightly noted, a lot of clinicians did recognize that infants did feel pain. So there's a really important anesthesiologist, neonatologist, who's now at Stanford, who really does the very first research and is not taken seriously because he's young and sick and nobody takes him seriously. But he really changes things. And the other question, the future. Yeah, I don't really know. I would say as a historian, I don't know how to predict the future. I do think that the NICU is a classic space for doing off-label and trying things that are, not tested, right? And I think clinicians really need to think carefully about doing that. And I think the history shows us that it is really, really dangerous and that it really leads, not only is it unethical, but it really leads to terrible outcomes for infants. And I don't think we can dismiss that. So one of the reasons I was so disturbed at the trial of the artificial womb is that, of course, clinicians are so positive that this will be really wonderful for neonates who can't yet survive otherwise. But there is no even thinking about what might it feel like for the infant, which I just find difficult to conceptualize. That's not a question that is asked. I think the attempt to try to improve care and to save neonates that you can't yet save kind of overwhelms the other questions. And I don't know what happens with AI, so I can't answer that question.
Well, thank you so much, Johanna. That was really wonderful. Thank you.